Okay, perfect. Okay, so to start, the first thing that we're going to do is differential diagnosis of conditions. We are going to talk about differential diagnosis for your cardiac conditions. Okay, starting with your, we are going to have a couple of main important conditions. We're going to start with abdominal aortic aneurysm. That's the first one that I want to talk about. What is AAA? What do we understand by AAA? What is AAA? Very good. It's a bulging in the abdomen. So your aorta continues down as your abdominal aorta. Now, when there is like a bulge in that abdominal aorta, what are the risk factors for that bulge in the abdominal aorta? What are the risk factors? Maybe the same thing, smoking, chronic hypertension. Maybe you have like some your atherosclerosis or any kind of block that can lead to your abdominal aortic aneurysm. What would be the typical signs and symptoms? What do you want to look for in the question? In the question, they're going to talk about pulsating mass in the abdomen. Okay, they're going to talk about pulsating mass in the abdomen. A pulse can be felt on palpation. Again, deep aching pain. Okay, there's going to be deep aching pain, and that aching pain is going to be in the back region, in the abdominal region, in the groin region. So in the back region, in the abdominal region, in the groin region, you may have like deep aching pain. What else? Groin region pain can radiate to the back, groin, buttocks, sacrum, I mean your scrotum. That's where the pain is going to refer. What if this is not taken care? What if this is not taken care? Let's say there is an abdominal aortic aneurysm and it has not been taken care. If it is not being taken care, then that can rupture. If it ruptures, it's very bad because all your like in your legs, what does happen? You have your iliac arteries and everything. That iliac arteries and all of that is going to supply blood to your lower extremities. If the abdominal aortic aneurysm, I mean, ruptures, there is no blood supply. There is going to be complete lack of blood supply, ischemia, necrosis, etc., etc. That's correct. Okay, paralyzed, yes. So abdominal aortic aneurysm is a serious condition. It is a bulge in the abdomen, pulsating mass in the abdomen, risk factors same as your hypertension, atherosclerosis, etc., etc. Pain in the low back, pain radiating to the groin, pain radiating to the abdominals, deep aching pain, and treatment would definitely be the same thing. There would be antihypertensive medications that would be given. What precautions? So if you are the first one to diagnose an abdominal aortic aneurysm, if you feel an abdominal pulse, it has not been diagnosed before, you feel that pulsating mass, you feel that the patient is having like a low back pain, what do? It is an emergency. You are going to refer them immediately. Okay, you're going to refer them immediately because that person has not been diagnosed of AAA yet. Okay, it's an emergency. But if the patient is already diagnosed with AAA, is on medications, then you have to exercise that patient, right? We have to exercise the patient like how we exercise any other cardiac patient. What are the precautions that you need to take? What are the precautions that we need to take? What are the precautions you need to take? Firstly, always we are going to do low intensity exercises. Good. We're not going to do anything that increases the abdominal pressure. That means no gait belts, no Valsalva maneuver. So whatever you're going to do, you're just going to do low intensity exercises, no gait belt, no Valsalva maneuver. Okay. How is the question going to come up to you based on abdominal aortic aneurysm? It may just be simple, but you may have to diagnose the AAA in the question. For example, if they talk about that a patient with chronic hypertension is undergoing a PT and the patient is going good, but when the treadmill speed is 3 miles per hour, he's fine. But when the treadmill speed is increased to 5 miles per hour, the patient starts having pain in the low back, buttock, and abdomen. But again, when you put it back to 3 miles per hour, the pain usually disappears. What is it? Is the patient demonstrating angina? Is the patient demonstrating congestive heart failure? Yeah, or should you stop the exercises and consult the physician immediately? Or the patient is having like a musculoskeletal back pain? You should immediately. Why didn't you think about musculoskeletal back pain? Because back pain is going to be there all the time when they walk. It's not suddenly going to increase or decrease with the speed, like with 3 miles per hour, 5 miles per hour. It's not going to fluctuate that way, right? But this is something that is there when you're increasing the intensity. So that is why you have to stop. To answer your question, Philip, yes, there are 3 sizes. There is like a small AAA, there is a medium AAA, there's a large AAA. I don't know if you guys need to know that. I don't think so you need to know that. But if your mass is somewhere between 3 to 4, it's small. Between 4 to 5.5, it is medium. And greater than 5.5 is a large abdominal aortic aneurysm. Typically, larger ones are the ones that require surgery. Okay, the larger ones are the ones that require surgery, but otherwise, that's it. You don't need to know more. Just because you asked, I mentioned the size of the abdominal aortic aneurysm. Okay. All right. Now, the other condition that we have is your angina pectoris. What is angina pectoris? Very good. It's a chest pain due to ischemia. When there is ischemia, that means when the demand, like when there is not enough blood reaching the heart, it's going to cause chest pain. It's going to cause pressure. It's going to cause chest tightness, and that is called as angina. What is the sign that we use for angina? We use the Levine sign. Levine sign means a clenched fist over the sternum. So it's basically it's like a clenched fist over the sternum. That is the Levine sign that is present with your patients with angina pectoris or myocardial, or ischemia causing the angina. Now, why do you get angina? You get angina because of the imbalance. Now, there is an imbalance between the demand and the supply. So your heart's demand is too high because it has to do a lot of activity. Maybe you're doing a lot of activity, which is why the heart needs to pump out a lot of blood. But the heart is not getting that much blood. It's not receiving because of the ischemia. So when there is an imbalance between the demand and the supply, that is basically causing angina. So when your heart is not receiving enough blood, but the demands are a lot high of the body, that means the heart needs to supply a lot to the entire body. When there is an imbalance between the myocardial oxygen demand and the supply, it leads to angina. Levine sign is a clenched fist over your sternum. Okay, it's accompanied with angina pectoris. The patient is going to have like a clenched fist over the sternum. That's called as a Levine sign. Okay, any particular risk factors that increase what all increases the demands on the heart? What all increases the demands on the heart? Exercise, stress, smoking, overeating, cold weather, or like vasospasm of the arteries, atherosclerosis, anything, all these are going to increase the demand on the heart. Okay, those are going to be your risk factors for your angina. Now, angina is going to be 3 types. Okay, angina is going to be a stable angina, unstable angina, and a variant angina. Variant angina is also called as a prismental angina. What is a stable angina? What do you understand by stable angina? When the chest pain is only with exertion, very good. When the chest pain is with exertion, when the chest pain subsides with rest, and it is predictable, yes, it has a predictable RPP. What do you mean by a predictable RPP? What is RPP? What did I mention in the last class about RPP? Heart rate into the systolic blood pressure is your RPP. So if you know that, okay, this much heart rate and this much systolic blood pressure, if I keep on going till that point, I'm not going to experience angina. But if I exceed that particular RPP, I'm going to experience angina. That is predictable, and that is stable angina. Stable angina is predictable. It will only come when you exceed a particular RPP. When you rest, it is going to go away. It is not an emergency. Will it respond to nitroglycerides? Yes, it will respond to nitroglyceride. Okay, so it is chest pain with exertion, chest pain that subsides with rest as well as with nitroglyceride, and it occurs at a predictable RPP, and it is not an emergency. That is your stable angina. What about unstable angina? What is the difference in unstable angina? Unstable can happen at rest. Does not require any exertion to happen. Does not subside with nitroglycerides. Okay, pain goes on increasing in severity, in frequency, in duration, it can progress to myocardial infarction. So unstable angina occurs at rest. It occurs at night too. It does not subside with nitroglyceride. It basically lasts for a longer time. Now you try giving angina. How many times? I mean, you try giving nitroglyceride. How many times do you give? You give 3 doses, and you every 5 minutes. If it does not respond, you have to call emergency. So yes, unstable angina is 911 before it turns into a myocardial infarction. Okay, and the last type is called as a variant angina. Variant angina, also called as a prismental angina. Variant or a prismental angina is something, is it because of the occlusion of the arteries like the other angina? No, it is not because of the occlusion of the arteries. That means it is not because of atherosclerosis. Then what is it because of? It is because of the vasospasm of the arteries. That means your arteries are going into spasm. Why are the arteries going into spasm? It could be stress, anxiety, emotional stress, like anxiety, emotional stress, anything related to your health. A lot of people, younger people, they get a lot of cardiac arrest and everything. They get a lot of chest pain. That's because of the vasospasm of the arteries related to stress, anxiety. Okay, emotions basically. So a vasospasm of the artery without any history of occlusion, that means no atherosclerosis, nothing. When they have like a chest pain, which is with the absence of occlusion, that is only because of the vasospasm of the arteries, that is called as a prismental angina or a variant angina. Does this respond to nitroglycerides? This also responds to nitroglycerides. Only unstable angina does not respond to nitroglyceride. Remember, angina is going to be chest pain, that is heaviness, squeezing, aching, burning, tight pain. Pain sometimes radiates to the upper back region, neck region. Okay, so that is something that we typically see with angina. All right. Now, now, if you have, what are the changes that we see in angina? No, variant angina is not an emergency because once nitroglycerides are given, it's going to go down. It is going to work with nitroglycerides, so it is not an emergency. Now, what are the changes on an ECG that we see with angina? We discussed it last time. What are the changes on an ECG that we see on an angina? Q wave is myocardial infarction. It's not angina. Pathological Q wave is myocardial infarction. Okay. Pathological Q wave is myocardial infarction, and sometimes it's an indicator of silent ischemia. But what are the ECG changes that we see with ischemia? Yes, you all know ST segment depression. Didn't we do it on Tuesday class? ST segment depression, and what was the other thing that we did? ST segment depression and, come on guys, what did we do? T wave inversion. What is happening? ECG, T wave inversion, ST segment depression. Didn't I say that is for ischemia? What happens in angina? Ischemia, right? So T wave inversion, ST segment depression, horizontal or downsloping. Is it upsloping? No. Horizontal and downsloping ST segment depression and T wave inversion could indicate ischemia or could indicate angina. Okay. Now that was about your angina pectoris. Everyone with me? These are easy stuff, so we are going quick. When we come to exercise prescription, we will reduce our pace. Okay. This is stuff you already know. Okay. Now we come to myocardial infarction. MI. What is the difference between the angina and myocardial infarction? Now, when you have a prolonged ischemia, to the heart, okay, when you have prolonged ischemia, it leads to the death of the myocardium. It leads to the death of the myocardium, and because maybe 1 or 2 or 3 arteries are now completely occluded. If 1, 2, 3 arteries are completely occluded, there is no blood supply to the heart. That leads to the death of the tissue, and that is your myocardial infarction. So that means that part of your myocardium stops working. If it stops working, what will it not be able to do? If you have a myocardial infarction, what will it not be able to do? It won't be able to contract properly. If it doesn't contract, there is no blood supply to your extremities. If there is no blood supply to your brain, extremities, what all do you see? Sorry. If there is no blood supply to your extremities, okay, you see cyanosis, okay. What will happen if you see there's no blood supply to your brain? Confusion, coma, loss of consciousness, no blood supply to the extremities, excessive fatigue, right? So along with chest pain, that is something you are going to see with myocardial infarction also. You're going to see severe chest pain, you're going to see shortness of breath, but along with that, what is addition? Addition means there is no blood supply to your other body parts, which is why you're going to have fatigue, you're going to have confusion, dizziness, syncope, excessive sweating, that is diaphoresis, okay, pain radiating to the arm, the jaw, the back. All of that is something that is going to be associated with myocardial infarction, okay? So what was the difference between ischemia and your myocardial infarction? Ischemia was you have a ischemia, your angina pectoris was just the chest pain. Angina is just the chest pain because of your reduced oxygen demand. But what happens in myocardial infarction? Myocardial infarction is the death of the tissue because of a complete occlusion of the artery. Because of that, along with severe chest pain, along with pain radiating to the jaw, arm, back, along with shortness of breath, you will also see fatigue, weakness, syncope, coma, confusion, dizziness, your diaphoresis. Diaphoresis is excessive sweating. So all of these things are going to be accompanied along with myocardial infarction. Myocardial infarction means now there's going to be a problem with the left ventricle. If there's a problem with the left ventricle, what happens to the stroke volume? Problem with the left ventricle reduces. What happens to the cardiac output? Decreases. What happens to the ejection fraction? Decreases. So everything is reduced, which is why you are not getting any blood supply to the other parts. So with myocardial infarction, all of that is going to be reduced. Most of the time, it is the left ventricle, Chris, because left ventricle is the one that's going to pump the blood to the other parts. So it's always going to, whenever they talk about myocardial infarction, it is, if it infarcts, that means your left ventricle is stopped working. Okay. Now, this is not that important, but I'm just going to quickly go over this. Okay. Now, in your heart, you have like these three zones. The outermost zone is called as the zone of ischemia. Okay, that is like, that means only like in your heart, like if it's like the outermost zone, that's like a zone of ischemia. So that's when it's like the patient's ECG is just going to show ST segment depression or T wave inversion. Then you have like a zone of injury that is next to your zone of ischemia. And inside you have the zone of infarction. So zone of injury is the one where they start having the ST segment elevation. From here, they start having the ST segment elevation. That's your zone of injury. And your zone of infarction means that tissue is completely like necrotic. It's dead. It's a non-contractile tissue. That's a pathological, that's when your ECG is going to show a pathological Q wave. That is why we say, right, pathological Q wave has a history of myocardial infarction because that tissue is completely dead. Okay, it's basically like a necrotic and a dead and contractile tissue. So that's like your zone of infarction. So nobody's going to ask you this in the exam. This is just, I'm telling you that first it's the zone of ischemia, then the zone of injury, and then it is the zone of infarction. Now, when have you heard about the terms STEMI and non-STEMI? Okay, what is the meaning of STEMI? Nothing great. It's just that ST segment elevated myocardial infarction. Non-ST segment elevated myocardial infarction. Okay, what does that mean? You can either see a myocardial infarction that will come with ST segment elevation, or you'll see a myocardial infarction that will come with non-ST segment, non-ST segment elevation. Okay. Yes, Beatrice, it can be ST segment elevation greater than 1 mm also. That's not, you can have that. Okay, that's not a problem. In your exam, they would not expect you to know the zones or anything because the exam is more clinical. Okay, so ST segment elevated myocardial infarction, non-ST segment elevated myocardial infarction. Now, when do you get ST segment elevated myocardial infarction? When your full thickness of the myocardium, that means all your tissues, whether it's your epicardium, your endocardium, your myocardium, everything, all the tissue together is getting affected. You get an ST segment elevated myocardial infarction. But it's also called as transmural. If you want to know the other word, that's also called as a transmural. What do we mean by transmural? Transmural means your entire myocardium is the one that is now getting affected. Okay, entire myocardium is going into an infarction. But what is non-ST segment elevated myocardial infarction? Means only an outer layer, either the epicardium, either the subepicardium, only like a part is affected, then you will not see an ST segment elevated myocardial infarction. Okay, you will not see like a Q wave, or you'll not see anything like that. Again, this is just for your information that usually when you have a myocardial infarction, if it is a transmural myocardial infarction, means that all the tissues of the myocardium are mainly affected, and that causes ST segment elevation. When it's only the outer layer or something that is getting affected, it will not show ST segment elevation on the ECG. Everyone clear? And if you identify ST segment elevation greater than 1 mm, what do you do? On an ECG, if you identify ST segment elevation greater than 1 mm, then what do we do? 911. Yes, you stop and you call 911. Exactly. Right? That is correct. Okay, everyone clear with these conditions so far? What is myocardial infarction? What is angina? What is abdominal aortic aneurysm? Okay, now very important is your heart failures. Extremely important. Okay, you may have questions on heart failure. Make sure to do the classification of heart failure from your textbooks, okay, from your reading material, but we are going to go mainly over the types of your heart failure. Now, before we go on to just going to the signs and symptoms, let's talk about the cause of it, okay? Once we know that, it becomes very easy, okay? Now, my horrible drawing, I apologize. Okay, now this is your lung, your right atrium, your right ventricle, your left atrium, your left ventricle, okay. Now, when you have your, let's see here, superior vena cava, inferior vena cava. Okay. Now, when you have a problem with the tricuspid wall, let's assume that there is a problem with the tricuspid wall. Let's say tricuspid wall stenosis or something is happening to the tricuspid wall. What will happen? When there is a problem in the tricuspid wall, what happens? When there's a problem in the tricuspid wall, that means there's going to be a backflow of all the blood into the right atrium. From the right atrium, where is the blood going to go? It's going to go to the superior vena cava and your inferior vena cava. So now it's going down to the body, right? It's going down to the body. So if I tell there is a problem in the tricuspid wall, what kind of heart failure will it cause? Will it cause a right-sided heart failure or a left-sided heart failure? Right-sided. See, you know it. Why? Because you know what is exactly happening. What if I tell you there's a problem in the pulmonary artery? So you see here, this is a pulmonary artery that's going to your lung. I hope you understand that this triangle is my lung. Okay, so if you have a problem in the pulmonary artery, if the pulmonary artery is stenosed, what will happen? Where will the backflow of the blood be? There is no blood that is going to the lungs, so there's going to be all the backflow back into the right ventricle, into the superior and inferior vena cava, again causing right-sided heart failure. So if there is any problem in your pulmonary artery, let's say pulmonary artery stenosis, or any problem in your tricuspid valve, that is going to lead to a right-sided heart failure, right? Everyone got that? If there is a problem here, if there is a problem in the left ventricle, okay, if there's a left ventricle, there's a problem in the mitral valve here. Okay, this is two cusp. Then where is the backflow going to go? If there's a problem in the bicuspid valve, then it's going to go to the left atrium. From the left atrium, where is it going? It's going to the lung. So whenever there is a backflow of all the blood into the lung, what is the type of heart failure? What is the type of heart failure that it is called? It is called as a left-sided heart failure. Good job. Okay. Now, if I tell you there is a problem, I hope you understand this is my aorta. If there's a problem in the aorta, if there is aortic stenosis, what kind of problem is it going to cause? Again, there's going to be a backflow into the left ventricle, to the left atrium, to the lungs, again causing left-sided heart failure. So we all know the causes of left-sided heart failure. What if I tell you a previous myocardial infarction and the left ventricle is not working properly? Let's say I tell you, because you know heart failure a lot of times happens after myocardial infarction, right? Once the left ventricle dies, and you have increased chances of developing heart failure. So again, if you have a previous myocardial infarction, left ventricle is not contracting properly, will cause the backflow of the blood into the left atrium and into the lung, causing left-sided heart failure. Okay, so previous left ventricle problem, myocardial infarction, your bicuspid valve or your mitral valve problem, your aortic valve stenosis, all of these are causes of your left-sided heart failure. Make sense? Everyone clear with the your causes of your left-sided heart failure? And you tell me, what are the causes of your right-sided heart failure? Tricuspid valve problem, pulmonary artery stenosis. Good. If I tell pulmonary vein stenosis, what would that cause? Pulmonary vein stenosis, left-sided heart failure. Good job, you guys know everything. Good, very impressive. Okay, awesome. Now, so those were your causes of your left and your right-sided heart failure. My next thing is going to be your signs and symptoms, very important for your exam. Every exam has one question on this. Cor pulmonale, yes, Philip, that would be your right-sided heart failure. What is cor pulmonale? Cor pulmonale is like a fibrosis. It's the fibrosis of the lung. So if the lung is completely fibrosed, it's not going to accept any blood. It's not going to accept any blood, so it's going to backflow of the blood back into the right ventricle to the superior inferior vena cava. Okay, so yes, your cor pulmonale, your tricuspid valve stenosis, and your pulmonary artery stenosis, all are causes of right-sided heart failure. Yes, cor pulmonale is your chronic COPD. Your last, not chronic, I could say the last stage COPD, end stage COPD. Okay, now your difference between your right-sided and your left-sided heart failure. So what did we see in left-sided heart failure? Where was all the backflow of the blood going into? Excellent, lungs. And where was the backflow of the blood going into the right-sided heart failure? In your body, into your periphery, into your body. Exactly, perfect. Okay, with both sided heart failure, what is the biggest problem? What is the biggest problem in whenever somebody has heart failure? What is our main concern? Ejection fraction, right? That's our main concern. Our main concern is the ejection fraction. That means your cardiac output. We are always worried about the cardiac output. The cardiac output is so low, right? With heart failure, the biggest problem is your reduction in your cardiac output. Where no matter what heart failure it is, your ejection fraction is going to be low, which is why your cardiac output is going to be low. That's our biggest problem with your heart failure. Okay. Now, your if your left-sided heart failure goes to the lungs, so if your ejection fraction, your cardiac output is low, what are you expecting the blood pressure to be? Excellent. You're expecting the blood pressure to decrease. To compensate for that, what are you expecting the heart rate to be? Good. So whenever you have like a left-sided heart failure, your main thing is going to be decreased blood pressure, increased heart rate, and all your lung symptoms. What are your lung symptoms? Dyspnea, shortness of breath, orthopnea, wheezing, crackles, because you have so much secretions, cough, right? You may have dry cough or you may have pulmonary edema. If you have pulmonary edema, what is the cough? It's going to be pink frothy secretion. Good. Okay, so left-sided heart failure can lead to pulmonary edema. We know that, right? It is the filling of fluid in the lungs. So always remember with left-sided heart failure, your first sign of symptoms are all related to the lung. Coughing, secretions, pink frothy secretions, dyspnea, nocturnal dyspnea, orthopnea. Okay, all this related to the lung. Second thing, blood pressure decreases, heart rate increases. And the last one, if you don't have good ejection fraction, you don't have good cardiac output, what happens to the blood supply to your body? What happens to the blood supply to the brain, to your body? All decreases, right? So weakness, fatigue, poor exercise tolerance, lightheadedness, dizziness, confusion, same thing that we saw with myocardial infarction, right? That is going to be your left-sided heart failure. BP always decreases with Chris. BP is always decreased with your left-sided heart failure. Okay, so this is going to be associated with your left-sided heart failure. Everyone clear left-sided heart failure? Now, there, Philip, clubbing? No, because clubbing is something that is seen with prolonged oxygen deprivation. What is something that is seen with short-term oxygen deprivation? That is cyanosis. Now, there is always going to be an ambiguity where is cyanosis seen? Is cyanosis seen in left-sided heart failure? Is cyanosis seen in right-sided heart failure? In reality, cyanosis will be seen in both because of the oxygen deprivation, but more leaning towards your right-sided heart failure. But in your exam, cyanosis is not the only option that they will give you that, okay, patient has cyanosis, what is the heart failure? No. See the other signs and symptoms and pick the most important thing. Okay. Yes, Dhruvi. Okay, crackles is your because of secretions, rails because of secretions. See, what is happening there is the lung is getting filled with fluid. If the lung is getting filled with fluid, of course, you're going to have secretions. You're going to have pulmonary edema. You're going to have pink frothy secretions. You're going to have crackles. You're going to have rails, right? So left-sided heart failure, all your signs and symptoms of the lung, blood pressure decreases, heart rate increases, lightheadedness, dizziness, fatigue, weakness, irritability, poor exercise tolerance, confusion, etc. are your signs of left-sided heart failure. What is the heart sound that we say? Heart sound. S3 heart sound. What is S1 heart sound? What is S1? It's your lub. What is S2? It's your dub. S1, S2 are normal. S1 is during the closing of your atrioventricular walls. S2 is during the closing of your semilunar walls. S3 is normal in what patients? What patients do you see S3 normally? Patients who are athletic, pregnant women, yes, you do see S3 normal in them, but you will see it in your left-sided heart failure. In both heart failures, whether it's left-sided, right-sided, we typically see your S3 heart sound. When do we hear S4 heart sounds? Yes, we can hear S4 in left-sided heart failure, but typically we will hear S4 with, there is going to be a left ventricular hypertrophy. When there is a left ventricular hypertrophy, that's when we see myocardial infarction, we see, and we can also see it in a left-sided heart failure. Okay, that's when we typically see a S4 heart sound. Everyone clear with the signs and symptoms seen with left? Very simple, just remember all the symptoms related to shortness of breath, coughing, secretions, then hypertension, blood pressure increase, okay? And you can also remember all your fatigue, weakness, poor exercise tolerance, etc. Yes, Crystal, S3 and S4 both can be heard with your left-sided heart failure, but mainly with heart failures, always pick S3. Okay. Although both can be heard, we always in the option, if they ask you, always pick S3 with your heart failure. Okay. With your heart failure, you are going to always pick S3. For heart failure, Beatrice, you do echocardiogram. In the echocardiogram, you will see that there is decreased ejection fraction. Okay. Now, what is the physiology of S3 heart sound? So S3 heart sound is before, it's just at the beginning of atrial contraction, and S4 heart sound is at the beginning of, at the end of atrial contraction. Both of them are related to ventricular filling. That's when you hear these sounds. So both S3 and S4 are related to ventricular filling. It's basically, it helps with the ventricular filling. S3 happens at the beginning of atrial contraction. S4 happens at the end of atrial contraction. Okay. So cardiomegaly can be seen with left-sided heart failure, not mandatory, Dhruvi. Okay, it's usually left-sided, left ventricular hypertrophy. If you see, then you could see cardiomegaly. Okay, but it may or may not be present. Now your right-sided heart failure. Right-sided heart failure, what is happening? Simple, we know all the blood is like all your backflow is going back into your periphery and your body. So what are the typical symptoms that you will see? Excellent. Edema, weight gain, bloating, cyanosis, ascites. What is ascites? Ascites is your liver, like fluid getting filled in the abdominal cavity in the liver. That's your ascites. Then your splenomegaly, all the organs becoming hepatomegaly, splenomegaly, all the organs becoming larger, right? Jugular vein distension. The jugular vein is going to be distended, leading to jugular vein distension. Yes, so cyanosis, jugular vein distension, right upper quadrant pain, ascites, weight gain, bloating, anorexia, decreased appetite. They will not feel hungry. They're always bloated. Anorexia, cyanosis, decreased urinary output. There's all water retention is in the periphery. That's called as decreased urinary output. Okay. Now, another thing that I want to tell you is what is the difference between, yes, core pulmonale, good Devanshi. Now, what is the difference between a compensated heart failure and a uncompensated heart failure? What is the difference between a compensated and an uncompensated heart failure? Main difference between compensated and uncompensated heart failure is compensated means it's not having these active signs. You will not see them having shortness of breath. You will not see them having bloating, anorexia, weight gain. No, the signs and symptoms are controlled with medication. Even though the cardiac output has not increased suddenly, the cardiac output has not gone out and increased suddenly. It is just maintained, but it is maintained in such a way that the patient is not showing the signs and symptoms. So they are functioning now with a reduced cardiac output and they're stable. They don't have any signs of decompensation. What do I mean by signs of decompensation? Means they do not have any active signs. That is called as a compensated heart failure. And what is uncompensated heart failure? Uncompensated heart failure is you are seeing all these active signs. That is your uncompensated. So do you give PT, physical therapy, or cardiac rehab in a patient with compensated heart failure? Yes, but you never give it in a patient with uncompensated heart failure. If you see active signs and symptoms, you do not give your physical therapy. Good? Next, what do you just want to ask? What do you understand by the term pericarditis? What is the meaning of pericarditis? Inflammation of the pericardium. Yes. Chris, no, I think Beatrice, in compensated, it is controlled by drugs. In uncompensated, it is not manageable. Okay, so pericarditis is the inflammation of the pericardium. So they are going to have a lot of pain, chest pain, fever, chills, because it's inflammation. Fever, chills, chest pain, coughing. Okay, how is the pain relieved? How do they experience relief in pain? They are going to have the usual cardiac pain to the neck, upper back, and all of that. The pain is going to be relieved by bending forward. When I do other systems, maybe I can talk about this again, but you have 4 P's. What are the 4 P's that are going to be relieved by bending forward? 4 P's. Correct, Betul. You have your pericarditis, you have your pancreatitis, you have your pleural effusion, and you have your pneumonia. Okay, pleural effusion and pneumonia. Why? Because you have shortness of breath. So you go forward and that kind of helps, right? But whatever side you have pleural effusion, lying down on that side helps. If you remember, we had done it, splinting the affected lung helps with pleural effusion. Pneumonia, yes, dyspnea relieving position, correct, Dolly. So pancreatitis, pericarditis, your pneumonia and your pleural effusion, these are your 4 P's in which bending forward is going to relieve the pain. Pneumonia, you don't lie on the affected side, you lie with the bad lung up, postural drainage. Think about that. You always lie with the opposite, on the opposite side with your bad lung up. Pleural effusion is the only one where you're lying on the same side because you want to splint the pain. Okay. Everyone good? Clear with these cardiac differential diagnosis? Everyone good? I want to take some time, like few more minutes, and also go over the peripheral arterial problems, like your peripheral problems, because those are also very important for your exam, like peripheral venous problems, peripheral arterial problems, extremely important for your exams. We can go over it quickly in few minutes, but I also want you all to know those tables which talk about the scales for claudication, the tests for arterial insufficiencies, tests for venous insufficiencies, because as a part of your cardiac examination, they can ask you those things like your ABI, your Ruber, your claudication. These things can come in the exam. So don't skip those, okay? I think you do have them in your readings, right? I think it does come in your reading, final frontier readings. So you should know them, okay? Now which are your peripheral arterial conditions? Which are your peripheral arterial conditions? What are your peripheral arterial conditions? Tell me your name. I will do it, Anushka. Give me some time. Okay, very good. It's your Buerger's disease, your diabetic angiopathy, your Raynaud's phenomenon, etc. Amazing. And then you have your PAD, peripheral arterial disease. That's your occlusive peripheral arterial disease, right? So whenever you have a peripheral arterial disease, it means that it is an occlusion of your medium and your large size arteries. So PAD is your chronic occlusive disease of the medium and the large size arteries. What are your risk factors? Who is more prone to developing peripheral arterial disease? Smokers, good. Hypertension, obesity, CVA, hyperlipidemia, all same risk factors, like your same thing. So they can develop peripheral arterial disease. That means it is an occlusion in your medium and your large size arteries. So what do you see? What are the signs and symptoms of a peripheral arterial disease? What are the signs and symptoms? Fatigue, okay. Fatigue, what else? Pulse, okay. Pulselessness, pulse absent, okay. Pallor, okay. Intermittent claudication, very, very important. What is intermittent claudication? That the pain is, you have cramping, throbbing pain, burning, aching, cramping kind of pain in your calf region, right? In your lower leg. You have that pain in your lower leg. When does the pain decrease? The pain decreases when you are resting. Always remember, intermittent claudication pain decreases with rest. When the claudication is very severe stage of claudication, does the pain decrease with rest? No, that is the only time they have rest pain. So intermittent claudication is like your pain is burning, aching, cramping, tightness, pain in your leg region that decreases with rest. If it becomes severe, then you have rest pain. Apart from that, you have fatigue, you have pallor on elevation, you have rubor on dependency. Then somebody said skin changes. Yes, you have skin changes. You have hair loss, nail changes, Correct. So all this is seen because it's an arterial problem. Yes, it can lead to arterial ulcer. Also, with severe stages, it can lead to arterial ulcers. It can lead to gangrene. It can lead to all of that. Difference between differential diagnosis for neurogenic and intermittent claudication is very important. A person with neurogenic claudication will have relief of pain when they bend, when they are doing walking uphill, or when you're doing bike riding. That will relieve the pain with neurological claudication. But will that relieve the pain with intermittent claudication? No. So that's your biggest factor for differential diagnosis. Okay. Now the next one is your thromboanginitis obliterans. What is this also called? This is not really common. It's not a disease that is common. It's also called as a Buerger's disease, also called as thromboanginitis obliterans. It is a chronic inflammatory occlusive disease of small arteries and veins. Okay, small arteries and veins get affected. So it is mainly going to be seen more distally. So it is symmetrical, and it's going to be seen more distally in the hands and the feet. Okay, typically seen in young people. It's mainly genetic related, genetic and chronic smokers. So genetic and chronic smokers are typically the ones who are affected with thromboanginitis obliterans, also called as a Buerger's disease. It is symmetrical, and they are going to have problems in the distal, basically distal upper extremity, distal lower extremity. So they have definitely more chances of gangrene, ulceration, because it's more distal, right? Cyanosis, cold skin. So same problem seen distally is your, yes, they have a glove and stocking kind of a distribution because it goes distal to proximal. It's going to be glove and stocking. Remember, it is symmetrical. It happens in upper extremity, lower extremity bilaterally. Okay, small arteries and veins. And it is mainly more distal. And again, it can also lead to your gangrene, and it could lead to gangrene, it could lead to ulceration. That is your thromboanginitis obliterans. The next one is your diabetic angiopathy. I'm sure all of you all know this. What is diabetic angiopathy? It's because of increased blood glucose. Increased blood glucose, diabetic angiopathy, there is decreased blood supply to the nerve, you develop peripheral neuropathy, and because you develop peripheral neuropathy, what are your signs and symptoms? Same, pain, paresthesia, numbness, tingling, and all of that leading to diabetic ulcers. You can lead to neuropathic ulcers. Neuropathic ulcers are also called as diabetic ulcers. So diabetic angiopathy, I think all of us know peripheral neuropathy. So that's the same thing. And another one is your, yes, you get it typically at the base of your great toe. That is because of the pressure there. It's called as a neuropathic ulcer. Okay, sole of the foot. Yes. And the next one is your Raynaud's phenomena. What is Raynaud's phenomena? Raynaud's phenomena is it occlusive? Is Raynaud's phenomena occlusive? No, it's not because of the occlusion. All this was because of occlusion, because of smoking, because of this, because of hypertension and all. But Raynaud's phenomena is not occlusive. What is it? It is a vasospasm of your small arteries. Like when your small arteries go into vasospasm, what could be the cause for these small arteries to go into vasospasm? Cold weather, emotional stress, caffeine, smokers, all of that can lead to the vasospasm. So you see your finger is cyanotic, or it may appear yellow. It may appear like completely pale yellow, or it may appear blue. There may be some tingling, numbness in there on the distal tip of the fingers. So some tingling, numbness on the distal tip of the fingers, that is going to be seen with Raynaud's phenomenon. All of these will have access. Yes, all of these are going to have decreased oxygen in that respective areas. It's not going to be generalized. It is wherever the problem is, there is lack of oxygen there. Okay. So the difference between the Buerger's and Raynaud's, yes, Buerger's is bilateral, Raynaud's is not bilateral. Buerger's is an occlusive problem, Raynaud's is not an occlusive problem. What is the treatment? The treatment is going to be just doing like now removing the person from the cold is going to be the treatment. For diabetic angiopathy, controlling the blood sugar is going to be the treatment. For peripheral arterial disease and thromboanginitis obliterans, you can't really reverse a lot of changes, although they are taking medications and all, but we are going to cover the treatment. Now, since you asked, we can do it right away. Yes, Raynaud's is going to be typically, Raynaud's is typically going to be on the hand and the feet. Yes, Devanshi, you can give hot therapy, but they're already in the cold environment, so you immediately don't put them in heat. You can first do some simple active range of motion before putting them into heat. You don't want a sudden change in the temperature. Okay, now your treatment, since we already are there, what is the treatment for arterial problems? If a person has peripheral arterial disease, what is the treatment? What is the treatment for arterial problems? Very good. Walking program. Graded walking program is very important. So treadmill program or walking program, that is the treatment. Avoid elevation, yes. Do you keep walking them even though they have pain? So we keep walking them. We walk them up to moderate near maximal on your claudication scale up to 2. You have a claudication scale, so you can go up to 2 on the claudication scale. Okay, up to 2 on the claudication scale is going to help them. And then once they reach there, you rest. Once the pain subsides, start walking again. So you do intermittent walking program, intermittent treadmill program, that is going to be beneficial for someone with arterial problem. Let's say somebody has diabetic ulcers. Could you still do walking program? You never give compression therapy. That's never a solution to arterial problems. Compression is not a treatment for arterial problems. So you never give compression therapy because the arteries are already compressed. You don't want to compress it. Compression therapy can never be given. Okay. What was my question? I forgot. Yeah, you will not walk if the person has diabetic ulcer. So what other exercises you can do? You can do biking, right? You could still do biking exercises. You could still do get the blood flow going. So biking exercises like non-weight bearing, bicycle, that can be done in case of this. Okay. Aquatic therapy, if they have an open ulcer, then I would not recommend, Joanna. Otherwise, you can do it. Okay, yes, very good. There are modified Berger-Allens exercise. What are modified Berger-Allens exercise? Anybody knows what is modified Berger-Allens exercises? So modified Berger-Allens exercises are postural exercises. So what they do is they make the patient do active plantar flexion, dorsiflexion for approximately 2 to 3 minutes. Okay, so they make them do active plantar flexion, dorsiflexion. Then they elevate the leg. Okay, they elevate the leg for 2 to 3 minutes. They see that the leg has become completely pale. Then they put the leg into dependent position. Okay, they put into dependent position when it becomes pink. And then again, they do plantar flexion, dorsiflexion, inversion, eversion, and then the patient lies flat under a warm blanket. Just to basically get all the blood circulation in there, they do these exercises. These are called as modified Berger-Allens exercises. Again, not a very common thing that will be asked, but in case there is something in your option which is called as modified Berger-Allens exercises, what is it? They elevate it, let it get pale. They put it into dependent position, let it get pink. Okay, if they get pink, then you make them do active plantar flexion, dorsiflexion, and then cover them in a warm blanket. That is your postural exercises called as a modified Berger-Allens exercises. Yes, if the patient has intermittent claudication, your treatment will always be a walking program. That is the best treatment for intermittent claudication. Okay. Black color skin in PVD, not really. You can get a brownish discoloration with hemosiderin deposition if it is a venous problem. Okay, or you can get black when it is gangrenous. Otherwise, it will not be black unless and until it is not gangrenous. It will be pale. Okay. Yes, you can do resisted calf exercises, but they are more beneficial for venous. All right. What are the venous problems? No, Philip, hemosiderin is always in venous. It's not in arterial problems. Hemosiderin is always in venous. Arterial can get only black if it is getting cynosed completely and there is a gangrene, then arterial will get black. But otherwise, hemosiderin is always a venous problem. Never pick hemosiderin for arterial problems, okay? Yes, your varicose veins, your thromboembolism, these are your venous problems. What is varicose veins? Just your swelling, your veins become distended, swelling, tortuous, that's basically your varicose veins. That's because you are standing a lot, right? That's because you are standing a lot, or it's seen mainly in women. Okay, so that, or it could be genetic. Those are varicose vein. But what is the most important venous problem that we are concerned about? Deep vein thrombophlebitis or DVT. Okay, it's basically a clot formation and inflammation in the deep veins. Why do you get it? Why do you get DVT? It's the same thing. DVT is a thrombophlebitis. Thrombophlebitis means inflammation of the vein crest, and DVT is a deep vein thrombophlebitis. If it's a superficial vein that is involved, like a saphenous vein, it will be called as a saphenous vein thrombophlebitis. So DVT is a deep vein thrombophlebitis because of good prolonged bed rest, immobilization. Okay, that's going to be your main cause of, yes, after a big surgery. Okay, that's going to be your cause of your DVT. What are the symptoms? What are the symptoms typically seen with DVT? What would be the symptoms commonly seen with DVT? Excessive pain in the calf, tenderness on palpation, warmth, edema, cramping, warmth, edema, pain in the calf, dull aching pain in the calf, redness. That is going to be that is basically your sign. That's your red flags. If you get a patient with aching pain in the calf, tenderness on palpation, warmth, okay, increase in the warmth, tenderness, pain, cramping in the calf. If they put these two things together, what is your response? What do you do? If you see a patient with warmth, tenderness, yes, 911 always. Because if you feel that you know a patient is developing DVT, if you don't call 911, and if there is some movement and all, it could become a pulmonary embolism, and that could get life-threatening, right? So there is no, so it would become pulmonary embolism, and it would lead to be life-threatening. So which is why if you are the one who's diagnosing a DVT, always 911. You do not do Hormon's test. Hormon's test is no longer done for DVT because it's not. If the patient has DVT and you do Hormon's test, you could dislodge it to a pulmonary embolism. So Hormon's test is something they no longer do for DVT. What do? They do a Wells criteria. Wells criteria is something that is done for DVT, not Hormone sign. You no longer do Hormone sign for DVT. You do the Wells criteria. What does the Wells criteria indicate? If you just need to know the total of the Wells criteria, there is a table. Okay, Joanna, there are some signs and symptoms in that table that, okay, does the patient have this? Does the patient have this? So it's a grading. You need to know the total in the Wells criteria. It just has to tick mark. Okay, it is to be graded between 0, 1, and 2. If does the patient have this? 1. Does the patient have this? 0. So it's basically a scale that needs to be graded. If they have with something that is greater than 3, 3 greater than 3, that means it's a high probability of developing DVT. Okay, if the Wells criteria is 3 greater than 3, high probability of developing DVT. Moderate probability if the Wells criteria is 1 or 2, and low, like no, is 0, right? So that's your Wells criteria. So Hormone sign is not something that you would prefer. You would prefer Wells criteria, WELLS, Wells criteria for your DVT. If your score is greater than 3, high probability of getting DVT. If your score is 1 to 2, moderate probability, and less than 1 is going to be 0. Okay. I don't think you need to know the components of Wells criteria. I haven't really seen them in any questions so far. Okay. Now, once a person is diagnosed with DVT, what do you do? After they have been given the medication, what do you do? After they have been given the medication? So you will do PT. It's very important to do PT after the first dose of the medication. So after the first dose of medication, that is your heparin or your warfarin is given, you have to start ambulation. You have to start leg exercises. If you don't start ambulation and you don't start exercises, what will happen? It will lead to a post thrombolytic syndrome. That means that there is blood clots that are breaking and you are causing the reoccurrence of that. Okay, so yes, this is for DVT after taking heparin. So a person who has already been given medication for DVT, you have to start with exercises. If you do not start with exercises, ankle toe movement, calf exercises, that means you are increasing the probability of post thrombolytic syndrome. Yes, within 24 hours of the medication, you have to start. The physician will tell you when, but after the first dose of the medication is given, you have to start exercises. Remember that. Okay. If you are diagnosing DVT, you never start. If you are the one who saw warmth, tenderness thing, 911. But once DVT is diagnosed and the patient has been given the medication, you have to start walking, you have to start exercising within 24 hours or after the first dose of the medication. Okay. To prevent DVT, what do we do? What do we do to prevent DVT? Walking, calf exercises, compression stocking. Okay. Compression stockings, these should be given. So the venous management, how do you manage a venous problem? You manage a venous problem by giving compression stocking. What should be the pressure in the compression stockings? Somewhere around 30 to 40 mmHg. Perfect. So the pressure is somewhere around 30 to 40 mmHg. Okay, compression stockings, ambulation, calf exercises, resistive calf exercises, these are the ones that is your venous management, okay? And to prevent DVT, you do the same thing. But if you diagnose a DVT, stop, okay? Yes, you should know the garment compression. You don't need to know the classification for DVT, but you need to know that for your lymphedema. Okay, for DVT, just remember to prevent DVT for venous problems, you can give 30 to 40 mmHg of pressure. Okay, you do your walking, you do your compression garments to prevent DVT. Once DVT is diagnosed, no PT, no compression, nothing, 911. But once the patient has already taken medication, you do the same things. You can still give compression garment after that. You can still give walking, you can give ankle to movement, everything. So before and after the medication, it's the same management. But when you actually diagnose the DVT, no exercises, nothing, just 911. Okay. Yes, you should never, your maximum pressure of the compression garment should never exceed the diastolic blood pressure, because that means you are compressing your arteries. Okay. Now the next thing is the management for arterial problems compression? Can you manage arterial problems with compression therapy? Never. Can you manage venous problems with compression therapy? Yes, but sometimes a patient may have a mix of an arterial problem or a mix of a venous problem, right? A patient may show up with that. What do you do then? Always check the ABI. How do you know the patient has a mixed problem? Before giving compression to any patient, whether arterial or venous, anyways, arterial, the problem, you don't give compression. But before giving compression therapy to a patient with venous problem, you want to check the ABI, not to diagnose the venous, because ABI doesn't talk anything about venous, but why are you checking the ABI? To know if it is a mixed problem. Because if it is a mixed problem, can you give compression therapy? No. What is the ABI below which you never should give compression therapy? ABI below 0.8. So anything 0.8, 0.7, 0.6, 0.5 or below, like you never ever give compression therapy. Okay, do you give compression greater than 1.2? ABI greater than 1.2? No. Okay, I'll come to ABI, 1 second. I'm going to tell you how to take ABI also, just 1 second. Yes, Manasa, I told that Venous problems can be treated with compression therapy, but before treating a venous patient with compression therapy, as for treatment purpose, in order to make sure that they do not have any arterial problem, you do measure the ABI. If the ABI is less than 0.8, you cannot give compression therapy to that patient having a venous problem. That is what I mentioned. Okay. Okay, now Chris, that there are a lot of mixed opinions in different textbooks. We don't follow that. We follow the lymphedema classification from Dr. Singh's class, where for lower extremities, it is acceptable to go 40 to 60. For upper extremities, we stick to 20 to 30. Okay, it is okay, 50, you can go with higher stages of lymphedema, you can go up to 60 mmHg but the only thing you need to take care is that you cannot go greater than your diastolic blood pressure, never. Okay. Sarah, that's why I told you that when you are giving a venous intervention, you check the ABI. You'll automatically come to know if they have an arterial problem or no. That is why before giving compression therapy to a patient with venous problem, you are checking ABI. Okay. Yes, DVT, your compression therapy garment average is going to be 30 to 40. Okay. Wait for it. I'm going to go over ABI. I will tell you all about the ABI. Okay. Up for lymphedema, follow exactly what is in Dr. Singh's class. That is more than enough. Okay, that's more than enough. All right. I was talking to you guys about the tests, your tests for arterial insufficiency, tests for venous insufficiency. I want you all to know those. What are the tests that they do for venous insufficiency? Do you guys have any idea what are the tests they are going to do for venous filling time? Very good. Venous filling time can diagnose both, can diagnose an arterial insufficiency and a venous insufficiency. What is normal venous filling time? Around 15 seconds. If it is significantly less, let's say if it's 10, 5, what does that indicate? If it is 10 seconds, 5 seconds, what does that indicate if it is 5 to 10 seconds? It indicates that there is a venous insufficiency because the venous valves are not competent. So if the venous filling time is less than 15 seconds, typically they'll tell you 5 to 10 seconds. That's going to be your venous problem. But if the venous filling time is greater than, let's say 15 seconds, if it's 20 seconds, 30 seconds, then it's going to be an arterial insufficiency. What is a gold standard for identifying a venous problem? What is a gold standard for identifying a venous problem? Doppler. Very good. Doppler is a gold standard for identifying venous problems. What are the other tests that we also do for venous? Not really important, but we do it. You may have seen, yes, your Trendelenburg test, your percussion test. Okay, these are given in your textbooks. They are given in your therapy aid also if you want to read about it. So your Trendelenburg test and your percussion test. So these are all your tests for your venous insufficiency. Percussion, Trendelenburg, I think Trendelenburg is also the tourniquet test. Where do we check for venous insufficiency? You could check it on the lower extremity. Okay, that's fine, Marnik. Venous filling test and your Doppler. What are the tests that we do for arterial insufficiency? Main is your ABI. How do you measure the ABI? How do you measure the ABI? Lower extremity divided by upper extremity systolic blood pressure. Now, what is the extremity? What is the lower extremity arteries that we use? We use the dorsalis pedis and the posterior tib, whichever is higher. So if you are treating a patient, okay, now I remember this. If you are treating a patient, let's say if you're measuring an ABI on the right side, okay, if you're measuring an ABI on the right side, you will take the blood pressure of the right side of the dorsalis pedis or the tibia or the posterior tibial, whichever is higher. Okay, whichever is higher. So if you're measuring the right side ABI, you will take your dorsalis pedis or your tibialis posterior, whichever is higher, what will you divide it by? You'll divide it by the systolic blood pressure of the brachial artery of either sides, either right or left, whichever is higher. Understood? So if you're measuring an ABI on the right side, the lower extremity has to be taken from the right side. So either the dorsalis pedis or the tibialis posterior of the right side will be taken. You divide it by the brachial artery of either the right or the left, whichever is higher. Got it? If you are measuring the ABI on the left side, then on the left side you take left side dorsalis pedis or left side tibialis posterior, and you divide it by brachial artery of either right or left, whichever is higher. Yes, that's correct, Dolly. Did you all understood? So brachial artery will be right or left depending on which is higher. But the lower extremity will be always on the side you are measuring the ABI. ABI measurements are extremely important for your exam. They always come in your exam. Okay, ABI measurements are very important in your exam. Okay. Now, what are your ABI measurements? Your normal is 0.9 to 1.1. Okay. What is your mild arterial disease? What is your mild arterial disease? Okay. What is mild? Everyone has different answers. I want one answer. What is mild arterial disease? 0.75 to 0.94. Okay. What is moderate? What is moderate? 0.5 to 0.74. And what is severe arterial disease? Less than 0.5 is your severe arterial disease. And what is falsely elevated arterial disease or diabetes mellitus? Greater than 1.12. Okay, so that is greater than 1.2. That is going to be a falsely elevated. What does it mean by falsely elevated arterial disease? That means there are calcium deposits inside. When you have diabetes mellitus or something, you have these calcium deposits, which is making the arteries really stiff. They become calcified. So which is why, can you do compression therapy on calcified arteries? That is why they say no compression even beyond 1.2. It's not really like a occlusion because of your atherosclerosis or because of hypertension. It is a calcification of the arteries. That is why they call it falsely elevated or calcified arteries. Understood? What is the other test that we do for arterial insufficiencies? Ruber of dependency. Yes, you don't give compression less than any ABI less than 0.8 or ABI greater than 1.2. To repeat myself, always less than 0.8, 0.7, 0.6, 0.5. You never do compression therapy, and you don't do compression therapy greater than 1.2. Okay. Yes, so so that is going to be, and your Ruber of dependency is your test, and your intermittent claudication. Okay, you already know your intermittent claudication. That is also your identification of an arterial problem. Apart from this, please know your edema grading, know your angina scale, know your angina scale, know your dyspnea scale, know your what else? Angina, dyspnea, claudication scale. All these scales are very important because they will be popped up in a question, just like the patient has 1+ or patient has 2 or anything, and you should be able to identify what they are talking. We're not going to go over every scale here, but you have to know the scales. Okay. What is the management for venous problems? What is the management for venous problems? Elevation, calf exercises, and still ambulation. You don't want DVT to develop, which is why ambulation is still going to be important. Okay. Yes, Anushka, there are two types, neurological and intermittent claudication. Those are your two types of claudication. That is correct. Everyone clear with all these differential diagnoses, what needs to be worked, what needs to be reviewed? All right. Now we're going to move on to an important part, which is going to be called as your exercise prescription. Okay. Filling test normal is 15 seconds. Lesser than 15 seconds is going to be venous insufficiency. Greater than 15 seconds is going to be arterial insufficiency. Most probably, they'll never give you exact less than 15. They'll tell you something like 5 seconds or 7 seconds, 8 seconds. If you see that, you will be able to identify that as a venous insufficiency. For arterial insufficiency, they'll tell you 25 seconds, 30 seconds, 20 seconds. Then you know it is an arterial insufficiency. Yes, that's correct. Neurological claudication is the same as your spinal stenosis. If you know spinal stenosis, you know neurological claudication. Okay. All right, let's move on. So how do you prescribe exercise intensity? We will have to move on to exercise prescription now, because this is also a very important part where I saw a lot of questions from y'all on the WhatsApp group. So I think we should move on, because the previous part that we did, if you listen to the lecture again, and if you even read it up, it's all just conditions, right? This is an important part which you guys need to understand. So let's start with your exercise prescription. How do we prescribe exercises? What do we do? We first do a exercise tolerance test. What is an exercise tolerance test? Exercise tolerance test can be maximal, or you can have a submaximal exercise tolerance test. What do we mean by a maximal exercise tolerance test? What do we mean by a maximal exercise tolerance test? A maximal exercise tolerance test is a Bruce protocol, that's correct. So the patient is exercising, you are going on increasing the speed. The patient is basically exercising at the maximum of his potential. 100% of the heart rate they are exercising. That is an exercise tolerance test. We typically don't do maximal exercise tests when it comes to cardiac patients. Why? Can they tolerate exercising at 100% of their maximum heart rate? No. So which is why this is done in advanced ACSM settings. Your Bruce protocol is a example of your maximal exercise test. And yes, we do not slow down maximal exercise tests. We either stop them if the patient says stop, or if you see signs, like if the patient is feeling the signs and symptoms, chest pain or something, you stop. But you never slow down the speed in a maximal tolerance test. The other one is a submaximal. What is a submaximal tolerance test? It is lower. It is something that we can do. It can go up to 85% of their maximum heart rate. So submaximum tolerance tests go up to 85% of their maximal heart rate. They never go up to 100. The maximum your submaximal test will be up to 85%, and they are symptom limited. What do we mean by symptom limited? That if the patient starts experiencing any kind of pain or fatigue or anything, you can stop the test. You can basically reduce the size. You can reduce the intensity. That is okay, which is why we typically do in cardiac rehab and everything, whenever we are doing a test, we typically do a submaximal exercise test. Now, what are the examples of a submaximal exercise test? What are the examples of a submaximal? Your 6-minute walk test, good. Your step test, your modified Bruce protocol. So step test, 6-minute walk test, modified Bruce protocols, all these are submaximal tests. Why is your ergometry good? All of these are submaximal tests because they are not going up to your 100% of the maximum heart rate. The maximum these tests will be up to 85% of the heart rate. Now, since you guys spoke about 6-minute walk test, what does the 6-minute walk test measure? What does the 6-minute walk test measure? This is important. Does it measure the distance? No. It measures your endurance or it measures your functional capacity. Always remember this. Sometimes they'll ask you in the question, does it measure the VO2 max? No, it measures your endurance and it measures the functional capacity. 6-minute walk test always is useful for measuring the functional capacity and the endurance of a patient. Everyone understood what is the difference between a maximal test and a submaximal test? There is no normal value for 6-minute walk test. 6-minute walk test is a patient is going to walk for 6 minutes. He can take as many breaks that he wants. He can use an assistive device. All you got to tell the patient is motivate the patient, okay, walk, right? So the patient can walk at a speed that is comfortable for the patient. Okay, the patient is going to walk at its own pace. They just need to travel as distance as much as they can. Yes, if they are taking a break, you never stop the timer with your 6-minute walk test. Good. Okay, so those were your key points for your 6-minute walk test. Everyone understood what is a maximal test and what is a submaximal exercise test? Okay, now what if they covered 530 meters in 6 minutes? 530 meters in 6 minutes, what does that mean? Is it good endurance? If they cover, so that it's basically it's just going to measure, like it's going to see how much distance they have covered. Okay, and even if I think 530 meters in 6 minutes, that should be, I'm bad at math, but yeah, it should be okay because they're walking at their own pace. It's not something that is going to be it's not something that's going to be qualifying them as it's based on patient to patient. Okay, and I think there's a formula that in the end that they use, that's basically, you don't do that formula, but they use a big formula to measure something for your 6-minute walk test. Okay, I will come to it. When do you do your exercise tolerance test? Yes, 1 minute. Yes, you can use any assistive device. Okay, now how do we prescribe exercise intensity? This is very, very important. So pay attention here. How do we prescribe exercise intensity? There are ways of prescribing exercise intensity. You can either use heart rate max, you can use heart rate reserve, you can use VO2 max, you can use RPE, you can use METs. So you all agree you can use all of this to prescribe your exercise intensity. Now, when to use what? Okay, let's start with heart rate max. What is the formula for heart rate max? There is some memorization that you need to do here. For once you do the memorization, you will get your questions correct related to exercise prescription. Your heart rate max is 220 minus age. Okay, so let's assume our age is 20 years old. So your heart rate max will be 200, assuming that the patient is 20 years old. Now, when you give a patient, this is important, remember this, when a patient is coming to you and wants to start exercises, okay, not an athlete, just a normal patient without any comorbidities. Let's say a 50-year-old patient comes to you, has no other comorbidities, just wants to start exercise program. You want to prescribe the intensity based on the heart rate max. Okay, you want to do it based on your heart rate max. How do you let's say how are you going to, what intensity are you going to use? Excellent. You can use 70 to 85% of heart rate max. You can use 70 to 85% of the heart rate max. Okay, that if the patient comes to you with comorbidities, can you use 100% of without comorbidities? Can you use 100% of heart rate max? You cannot use 100% of the heart rate max. So you use 70 to 85% of the heart rate max. Okay, now Your heart rate max is 220 minus age, 70 to 85% of heart rate max. Now assume that this patient has comorbidities, okay? Actually, I'll come back to that later. Okay, let's stick. Is everyone clear so far? This is going to be a little tricky concept, but everyone clear so far? You have to remember that if a patient has no comorbidities, start with 70 to 85% of heart rate max. Now, what is heart rate reserve? How do you calculate heart rate reserve? Heart rate reserve is calculated heart rate max minus heart rate rest. That is how you calculate the heart rate reserve. That is a formula how you calculate the heart rate reserve. Now, if you have been given the resting heart rate, can you calculate heart rate reserve? Just the age and the resting heart rate will be given. Can you calculate? Good. So what is the formula that you can use that uses the heart rate reserve? You can use a Carnovan's formula. Okay, you can use a Carnovan's formula. So first way, how we identified the target heart rate, the first step here. First step here was target heart rate is equal to 70 to 85% of heart rate max with a person with no comorbidities. So 70 to 85% of heart rate max for a person with no comorbidities. That is your first one, okay? The second one is your target heart rate is equal to 60 to 80%. What am I using now? What is this formula that I'm using now? It's not difficult at all, Anushka. If you see, you're doing nothing. You're just putting 60 to 80%. You are putting heart rate reserve there. What was your heart rate reserve? Heart rate max minus heart rate rest. That's it. And then you are adding this with your heart rate rest. This is your Carnovan's formula. So there are two ways how you prescribed intensity for a patient with no comorbidities. If the resting heart rate was not given to you, what did you use to prescribe exercises? If the resting heart rate was not given to you, what is the target heart rate? Target heart rate is the heart rate at which you are going to prescribe them exercises, right? So it was 70 to 85% of heart rate max. How do you remember what is the intensity when you want to use the Carnovan's formula? Just put 10 lower than the heart rate max. So heart rate max is 70. So what will be the target? What will be the one for heart rate reserve? It will be 60 to 80. So just remember that way. You just have to remember one. For a person with no comorbidities, you use 70 to 85% of heart rate max as your target heart rate. If the heart rate rest is given, you use your Carnovan's formula. Just subtract 10 from the heart rate max. So 70 will become 60. So you can do 60 to 80% of heart rate max minus heart rate rest plus heart rate rest. Make sense? Is everyone clear with this? Now, if you're bad in math like me and they ask you to calculate the Carnovan's formula, make sure that you first do 60% of this bracket and then you add it. Okay, I'm just going to explain it again. There are two ways that I taught you how to prescribe exercise intensity. One with the use of heart rate max, one with the use of Carnovan's formula. So far, I have just taught you based on the intensity that you use for a person with no comorbidities. That means no diabetes, nothing. They're just coming to you and they're telling you they want to start exercises. Okay. Yes, both is for no comorbidities. Just listen to me once, you will understand. Just hold on to your questions for a minute, okay? Because it's written on this, okay? So just 1 second, give me 1 minute. So target heart rate can be two things, okay? You can measure target heart rate using your heart rate max, or you can measure it using your Carnovan's formula. For now, I'm just telling you the intensity that has to be used for people without any comorbidities. If you're prescribing heart rate max, when your age is the only thing that is given to you, you have to use the formula for heart rate max. You have to use 70 to 85% of the heart rate max. for a person with no comorbidities. For heart rate, for your Carnot's formula, just subtract 10 from your heart rate max. What will happen if you subtract 10 from 70? It will become 60. So you use 60 to 80% and use this formula. Heart rate max minus heart rate rest plus heart rate rest. Now, when can you use this formula? What else should be given to you along with the age to use this formula? Resting heart rate. Can you use it without giving resting heart rate? No. So if the resting heart rate is not given in your exam, you cannot use the Carnot's formula to calculate your intensity. Now, does it make sense? Both of this is for no comorbidities. Okay. Now, that's what. Just you had to listen to me once. Okay. All right. Now the next thing is going to be, so this is 70 to 85, this is 60 to 80. Now I am just going to put in comorbidities, okay? Why am I teaching you? This is not only for cardiac, this involves all your exercise prescription. If you know this, you will get all the questions related to exercise prescription correct, okay? Which is why I am teaching you this. If you have a person with comorbidities, let's say diabetes, pregnancies, anything having some kind of comorbidities, what is the percentage that you use for heart rate max? You will use somewhere between 60 to 70. Okay, you can use somewhere between 60 to 75% of your heart rate max. Yes, somewhere less than 75. So 60 to 75% of your heart rate max. Now, this is what you use for comorbidities. Is this clear? Okay, so I want you all to remember this. Just remember 70 to 85 is what you use heart rate max for a person without comorbidities. 60 to 75 is what you are going to use for a patient with comorbidities. Yes, Betul, it's a range. So you always start with the lower and then you can progress accordingly. Okay, now whenever you are using the formula for heart rate reserve, that means you're using the Carnot's formula. Without comorbidities, you use 60 to 80. How much percentage will you use with comorbidities? 40 to 60% of your heart rate max minus heart rate rest plus the heart rate rest. Because 60 to 75 was for your heart rate max, for your Carnot's formula, it will become 40 to 60. Remember, it is lesser. Is everyone understanding? So if you, I'm going to repeat, if you have a person without comorbidities, resting heart rate is not given, you start with 70 to 85% of heart rate max. If you have a person with comorbidities, it will always be between 60 to 75% of heart rate max, not exceeding 75% of heart rate max. Let's say in your exam, resting heart rate is given, then only you can use the Carnot's formula. If you're using the Carnot's formula for prescribing exercise intensity for a person without comorbidities, you use 60 to 80. You start with 60 to 80. And with comorbidities, you put 40 to 60. Does it make sense now? Is that clear? Dhruvi, that depends. If the person is having obesity, means he has a comorbidities and you cannot use that. But if the person is not obese and it is fine, you can use that. You will have to calculate the range because they may give you the range in the exam. So it depends on how your options are given. So you may have to calculate the range in your exam. Okay. I'm going to make you all do a question on it, so you will get it properly. Okay, is everyone clear with these two things? Heart rate max, heart rate reserve. Now VO2 max, nobody is going to ask you to calculate, VO2 max, okay? They're just going to expect you to know the percentage of VO2 max that you use, all right? Chris, I think there's an error in what you've written. If for a person with comorbidities, it's going to be 40 to 60% of your heart rate, your Carnot's formula. So heart rate reserve plus the resting heart rate. And for maximum heart rate, it's going to be 60 to 75%. So your point number 1 is incorrect because it's not 40 to 60% of maximum heart rate. It's your heart rate reserve. Okay, does everyone understand this 60 to 40 and this 40 to 60 is the same for is the same formula, the Carnot's formula? Okay. All right. Now in your exam, if they ask you how much percentage of VO2 max, they will not ask you to calculate VO2 max. Okay. They will not ask you to calculate VO2 max. They may just ask you the percentage. An easy way for you to remember, copy the same percentage that you used for your heart rate reserve for your Carnot's formula. So if you had no comorbidities, what was the percentage that you used for your Carnot's formula if you had no comorbidities? 60 to 80%. So you can use 60 to 80% of VO2 max for a person with no comorbidities. And for a patient with comorbidities, what was the percentage that you used in Carnot's formula? Same thing. So you can use 40 to 60% of VO2 max. Easy to remember the percentage for VO2 max. Same thing as your heart rate reserve. Jumi, it was 70 to 85 with no comorbidities for your heart rate max, not for your heart rate reserve. I want you to calculate the one for your heart rate reserve. Copy that one. Okay. I'm going to quickly repeat it once more. I think a lot of you all are still confused. Okay. So your heart rate max is 220 minus H. That can be used when your resting heart rate is not given. The first basic question that I got 4 questions back was, what is target heart rate? Target heart rate is the heart rate at which you are prescribing intensity. So to get your target heart rate, you can either use a heart rate max formula or you can use a Carnot's formula. If you are calculating target heart rate with heart rate max, you can use 70 to 85% of heart rate max for a patient with no comorbidities, or 60 to 75% heart rate max for a patient with comorbidities. If you are calculating target heart rate with the use of Carnot's formula, when do you do that? When do you use Carnot's formula? When you have resting heart rate that is given. So when a resting heart rate is given, you use Carnot's formula. Most likely in an exam, they will not expect you to calculate the whole Carnot's formula. So don't worry. But you should know the formula because that could be asked. Okay. So what do you use for a person with no comorbidities? 60 to 80% of brackets heart rate max minus heart rate rest, bracket closed, plus heart rate rest. That is your Carnot's formula. If you are giving it for a person with comorbidities, 40 to 60% of the same heart rate max minus heart rate rest, bracket close, plus heart rate rest. What is heart rate max minus heart rate rest also called? It is also called as a heart rate reserve. In case they tell you what is heart rate reserve, you should know that. Okay, if you are using VO2 max, they will never ask you to calculate, but you should know the intensity to use. I told you easy way to remember, copy the intensity from your Carnot's formula. If you use 60 to 80% for no comorbidities and 40 to 60% with comorbidities. Now, does it make sense? Now you'll know what are the intensity that we use. Please say yes. All right. I'm just kidding. Don't worry. You can ask me if you've not understood. So just kidding. Okay. So everyone understood these 3 ways of prescribing intensity. Now, does anyone know how do you correlate RPE to your heart rate max? Does anybody know the mnemonic 4-3? What is it? 4-3-2-2-4. Good. 4-3-2-2-4. Okay, so that is how you are going to be able to identify what is the heart rate max related to the RPE. Okay, you have a table that will tell you how much RPE is how much heart rate max. So let's say you already know how much heart rate max you need to use. Would you be able to just identify the RPE from it? Yes, right? And same thing with the MET, right? You also have a formula for the MET. What is the MET formula? That is 42234. Okay, if you want, I will send those pictures on the WhatsApp group, which describe the mnemonics, so you can memorize it later on. But if you know this formula, you can identify. Okay, I will, Anushka, it's just a mnemonic that you need to know. I will send it on the WhatsApp group. Okay, in case you don't get the mnemonic, we will come to it later on because I really want to finish. If I elaborate this right now, we won't be able to finish exercise prescription. Okay, so the picture is very self-explanatory how to convert. It's nothing. It's just the conversion of RPE into heart rate max. It is the conversion of MET into heart rate max. So in case you know heart rate max, that mnemonics tells you how much RPE you are at or how much MET you are at. That's it. Okay, so if you know your heart rate max, will you be able to calculate the RPE and your MET based on that? Yes, so you will also know that. So these are the 5 ways you are going to prescribe exercises. Okay, if somebody does not understand the mnemonic, the next class I will be happy to explain the mnemonic to you again, but I think it's very easy and you will understand it. It's just how you convert RPE to your heart rate max. Okay, so this is how you prescribe exercise intensity. Does that make more sense now? Now I want you to apply this into a question. Okay, so I'm going to give you a question. This is a PDF. This is a PDF from your, this is just a question from your cardio assignments on NPT Final Frontier. I want you all to open this document that is just coming on your WhatsApp group and jump to question number 14 and solve it for me. Use what I taught you to solve the question. Okay, perfect. If your what is anything given except for the age in this question? In this question, is anything given except for the age? No. So what is the formula that you are going like? So what are you going to use? Are you going to use Carnot's formula? Are you going to use heart rate max? You're going to use heart rate max. It's okay. All right. You're going to use heart rate max. Now, what is the percentage that you use for heart rate max for no comorbidities? Perfect, 70 to 85. Why is C wrong? Why is option C wrong? That's maximum heart rate. You cannot exercise the person. Why is option A wrong? That's very little less, right? It's very less. Why is option D wrong? What does 85 to 95% of VO2 max indicate? Can I say 85% to 95 of VO2 max is almost equivalent to 100% of heart rate max? So again, that is not correct. C is wrong because Beatrice, C is 220 minus H. So that is 158. So you cannot exercise a person at its maximum heart rate. You have to use the formula 60 to 75. So that would become your 106 to 145 beats per minute. So that is why B. So everyone understood how to use this question now, how to use this concept? Great. Okay. Now this was just the one part. It was intensity. Okay. This was intensity. Now the next is we all know we have a fit principle, right? So you have your frequency. Now very important, if you have a high intensity, okay, now I always like to remember, this helps me with all my questions. Intensity is going to be inversely proportional. Intensity is inversely proportional to my frequency. If I am exercising a patient at a very high intensity, okay, if I'm exercising a patient at a very high intensity, what is the frequency that I should be doing? If I'm exercising the patient at high intensity, my frequency should be low. So anybody I'm exercising greater than 5 METs, okay, greater than 5 METs, my intensity is going to be 2 to 3 times a week. That is why, when you go to the gym, do you do weight training every day? No, you do it 2 to 3 times a week. But if you're doing cardio, if you're doing a low intensity exercises, what should be my frequency? It should be almost every day, 5 to 7 days a week. This is not only related to cardio, it is related to all conditions. Let's say you are exercising a person with diabetes, patient with pregnancy, a patient with obesity. What is the intensity that you use for these people? They are comorbidities. So what is the intensity? Low. So what becomes the frequency? You've seen all these patients, you give them 5 to 7 times a week, right? Duration, okay, timing is T. T stands for time or T stands for duration. Whenever you are giving exercises to these patients, even the low intensity, your duration should be good. So you should at least exercise them for, let's say, 30 to 45 minutes, right, to begin with. But is it necessary that if a patient is completely deconditioned or something, you have to make them exercise 30 to 45 minutes in one go? You can split it up. So you can split it up into 10-minute exercise session, maybe 4 times a day. How do you progress it? By breaking those 4 sessions into 2 sessions, then you could give 20 minutes, right? So that's how you progress. It's not necessary that you have to give them 30 to 45 minutes in one go, but giving them 30-minute exercise, 45 minutes exercise a day is good, but you don't want to give it in one stretch if they are deconditioned. Make sense? Type of exercise can be aerobic exercise, low endurance exercise, could be weight training, anaerobic exercise, all of those are types of exercise. So this is your FIT principle. It's very easy. First is your intensity. I told you guys how to calculate the intensity, okay? Intensity can be calculated with the use of heart rate max, heart rate reserve, VO2 max, RPE, METs, correct? Did you all understand the intensity part? Now the frequency part, Manas, I am repeating it again. Frequency is inversely proportional to the intensity. If your intensity is high, your frequency is going to be low. If your intensity is going to be low intensity exercises, your frequency will always increase. Low intensity is going to be high frequency, 5 to 7 times a week. High intensity, that is greater than 5 METs, it's going to be 2 to 3 times a week. Similar to resistance training will be 2 to 3 times a week, but if you're just doing simple aerobic exercises, it can be 5 to 7 times a week, okay? And the time for your exercises should at least be 30 to 45 minutes. You can break it down, okay? You can break it down into 10-minute sessions. I'm going to give you a practice question with numbers so it will become easier. I just wanted to explain you the concept before giving you the practice question. Does everybody understand the FIT principle? For deconditioned patient, Betul, if you have a patient with obesity, if you have a patient with pregnancy, the total duration of exercise, you still do 30 to 45 minutes. But if they're deconditioned, you cannot expect them to start with 30 minutes of exercise at one stretch. You can always break up their session into 10 minutes, 10 minutes, 10 minutes, 4 times a day. But when you progress them, you always progress with the duration first before progressing with the intensity. Progressing always with duration first. So if a person is exercising for 20 minutes, you can make their duration 30 minutes, right? But, or will you just exercise, or will you just increase the intensity first? What would you do? Would you increase the duration first or the intensity first? You always progress with the duration first before progressing with the intensity. Yes, Divya, resistance is only 2 to 3 times a week. Okay, let me give you guys one more question. This is from your final frontier exam. This will tell you how I am making you all use this concept in any question that comes. You don't need to sit and memorize ACSM guidelines for everything. You will know how to apply these questions when they ask about intensity. Okay, let me give you a question. Let's see if you are able to answer this question. Please use the concept that I just taught you. You should be able to answer it. What is the question telling? What does the patient have? Patient is obese, so it has comorbidities. According to our exercise prescription, what should we use for comorbidities? (40 to 60% of heart rate reserve). It is 60 to 75 for what? Heart rate? What is given in the question? Reserve or max? In the options. In the options, have they asked you reserve or max? They've asked you reserve. So what will be the answer that you will choose? 40 to 60 or 60 to 80? So can you eliminate option B and option D? Yes. Now, is the intensity low or is the intensity high? So what will be your frequency? 5 days a week. And should you exercise just for 15 to 20 minutes, or you can exercise the patient for 30 to 45, but break it down into few sessions? 30 to 45, and you want to break it down. So your answer will be A. Now you know with numbers how this will help you, how this fit principle explanation will help you. Beatrice, I think you chose 60 to 75 because you thought that it is asking you the heart rate max, but it is asking you the heart rate reserve. This is the formula for your heart rate max minus heart rate rest is your heart rate reserve. Okay, I think I want you to listen to it again, and you will be able to figure out what to use for heart rate reserve, what to use for heart rate max. Okay. I'm happy to hear that, Marmik. This is a confusing concept, but once you are able to nail this, you will get your exercise prescription questions always correct. You always progress by increasing duration before ever progressing intensity, because you have such a big range of intensity. You can always progress duration before you jump on to increasing intensity. Okay. These three are the most important: heart rate max, heart rate reserve, VO2. Rest, RPE, METs can be converted by the formula that I sent you on the WhatsApp group. Okay. All right. What is a normal response? Just some light stuff now. What is a normal response of heart rate and blood pressure to exercise? What is a normal response? Heart rate increases, blood pressure also increases. Whenever you do exercises, heart rate will always increase, blood pressure will always increase. If you have a deconditioned patient, what is the resting heart rate? High or low? Their resting heart rate is going to be high. What will be their heart rate recovery? That means after the exercise, how fast will the heart rate come back to normal? Will it come back immediately or will it come back slowly? Their heart rate recovery is slow. For a conditioned patient, what is the resting heart rate? Low. And what is the heart rate recovery? High, faster. Okay, everyone understands this concept? Perfect. So you know your normal response of exercises to your heart rate and your blood pressure. You also know your conditioned and deconditioned. Good. Now Valsalva maneuver. Okay. What is Valsalva maneuver? Valsalva maneuver is what is Valsalva maneuver? When you are breath holding. Okay. When you are breath holding. Okay, Valsalva maneuver is an increase in the intrathoracic pressure when you're doing an exercise with a breath hold. That is Valsalva maneuver. So what happens with Valsalva maneuver with the BP and the heart rate? Excellent. With Valsalva maneuver, I want you all to remember that with Valsalva maneuver, your BP increases and your heart rate decreases. Okay. This is what happens with your Valsalva maneuver. Always remember this. BP increases and the heart rate decreases. Do you encourage Valsalva maneuver in cardiac patients? You never encourage Valsalva maneuver, except we learned in ECG that we use it for a patient with supraventricular tachycardia, but otherwise we do not use Valsalva maneuver. Is everyone clear so far? Okay. Now, one more concept before I go to the phases of cardiac rehab. When we do what exercise? So when we do an upper extremity exercise, lower extremity exercise, okay? Which after a cardiac, like let's say after a person has just come back from a cardiac surgery or anything, what do we prefer? Do we prefer lower extremity exercises to begin with, or do we prefer upper extremity exercises to begin with? Why lower? Lower because lower extremity muscles are bigger. They can utilize oxygen. They can utilize oxygen really well. That means the VO2 max. What is VO2 max? VO2 max is the oxygen that is utilized by your muscles. So your oxygen can be utilized really well with your lower extremity muscles. Okay, but with the upper extremity muscles, they are very small. So there is a lot of oxygen consumption, but they cannot utilize it well because there are small muscles. So the VO2 max for upper extremity is around, I can say, 35 to 45% higher than lower extremity. Okay, so why is your VO2 max 35 to 45% higher in upper extremity as compared to lower extremity? I'm sorry, I'm sorry, there's an error here, lower. I'm so sorry. I meant lower than the lower extremity. Sorry. VO2 max in your upper extremity is 35 to 45% lower than the lower extremity. Why? I just mentioned you the reason, right? That the muscles are very small and they cannot utilize the oxygen well. So if they cannot utilize the oxygen well, can I say more demand on the heart? More stress on the heart? Can I say that the blood pressure increases, heart rate increases, but my stroke volume and cardiac output is still less? Right? So that is why we always start with lower extremity exercises over upper extremity exercises. Why? Because with upper extremity, Betul, this is all for upper extremity. Lower extremity exercises are prescribed more than the upper extremity exercises. Why? Because the upper extremity musculature is small. Your VO2 max is 35 to 45% lower in the upper extremity as compared to the lower extremity. That is why it puts more stress on the heart. The stroke volume and the cardiac output is decreased, and the blood pressure and the heart rate will be increased. So this is whatever I typed is for upper extremity, which is why you prefer lower extremity exercises over upper extremity exercises. Is this okay? Does this make sense now? Everyone clear with this? Yes, Betul, because VO2 is your oxygen utilization. Your muscles are very small, so they cannot utilize good amount of oxygen. Okay, so they cannot really utilize the oxygen. Your muscles are not getting enough oxygen, so it keeps on taking more and more, but doesn't utilize it well, which is why the stress on the heart is more. The heart needs to pump out more blood. Okay, the Devanshi, it's right here. For a deconditioned patient, the resting heart rate is high, the recovery of the heart rate is slow. And for conditioned patient, the resting heart rate is low and the recovery is high. Fast, then the recovery is 1 minute. Yes, and the recovery is high. Okay. Yes, they are small, they cannot use the oxygen well, so the demand on the heart is more. That is why we prefer lower extremity exercises over upper extremity exercise. Is everyone clear? I know this was too much loading of information, but this is what you need to get your questions correct, which is why I don't mind repeating it again and again, but I want this to get thorough. Deconditioned means a person who's not conditioned, does not exercise, is sedentary, that is a deconditioned person who's obese, person who has comorbidities. Fit versus unfit, you could say that, yes. Okay, everyone clear? Can we move on? We have 2 more concepts to do. Okay, the next thing you will have to repeat, you will have to listen to this lecture again because it has a lot of information, but trust me, once you listen to it and you just nail down these key points, you will be fine for cardiac exercise prescription. Okay, and your rehab. Now, your stages of cardiac rehab, we follow Hill-Glass. Okay, your stages of cardiac rehab, we are going to follow your Hill-Glass textbook, which has 4 phases. Okay, your ACSM has 3 phases, your therapy aid has 3 phases. We follow 4 phases. There's nothing different. It's just that there is addition of 1 stage. That's it. There's no other difference. The names don't change. What is the first phase called? First phase is called as the inpatient phase. Now I want you all to pay attention here. First phase is called as your, yes, Hill-Glass is accepted by the NPTE. That is what your PET uses, which is why we are using your Hill-Glass textbook here. Okay, there is not much difference. I'll tell you the difference between both. So in your exams, they typically will name the stage. Your inpatient phase is your phase that is used by your, that's your first stage 1 of your cardiac rehab. Okay, stage 1 is your inpatient phase. It's also called as your acute phase. Now, I want you all to tell me, what is this phase? This phase is in the hospital, right? The patient is in the hospital. It is immediately your 3 to 5 days of your hospital stay. It is that one, okay? That when they're staying in the hospital, this is that stage. Do they require monitoring all the time? Do they require continuous monitoring? Continuous monitoring is required, okay? They do require continuous monitoring. What about, they do require continuous monitoring. What is the MET? What is the MET for this phase? The MET that you do is not more than, in this phase, you cannot exceed the MET more than 5, but typically your MET will be somewhere between your 2 to 3, okay, 2 to 3 or 3 to 4, but it will not exceed 5, okay, so it will be low METs. What will be your heart rate max? What will be your heart rate? If you're prescribing exercises, it will be up to 70% of your maximum heart rate. So you are not exceeding 70% of your maximum heart rate. If I have to say heart rate reserve, what should I say for heart rate reserve? Can I say 40 to 60? Good job. Yes, I can say 40 to 60. Excellent. Okay. What is the RPE that you use here? 11. Okay. And your exercise that you do should not exceed 10 to 20 beats per minute over your resting heart rate. So if my resting heart rate is 70, the max that I should go in this phase when I exercise should be 90, right? So 10 to 20 above my resting heart rate, I can go. So this is what you have in your stage 1. Stage 1 is your inpatient phase, acute phase in the hospital. They require continuous monitoring. Their MET is not more than 5. They are up to 70% of your maximum heart rate. The RPE is 11 and their exercising is 10 to 20 beats per minute. Now, what kind of exercises are you going to do? Simple walking, simple ADL exercises, making them independent, patient education. What exercises? Lower extremity or upper extremity? Lower extremity exercises preferred over your upper extremity. What will be the exercise to the rest ratio here? What will be the exercise to the rest ratio? Your exercise to the rest ratio is 1:1. What do I mean by 1:1? If I exercise for 1 minute, I rest for 1 minute. Exercise for 5 minutes, I rest for 5 minutes. So it's going to be 1:1. Do I give exercises all in one go, or do I start with exercises 3 to 4 times a day? I start with exercises 10 minute sessions 3 to 4 times a day. And then how do I progress it? 20-minute sessions 2 times a day. Right? That is my progression. So I start with 10-minute sessions 3 times a day. So this is my phase 1. That is my inpatient phase, acute phase. Everyone clear with phase 1? Phase 2 is going to be my subacute phase. Okay. You would not need to do passive range of motion, Anushka, because you are doing active range of motion, right? You're doing simple mobility exercises. You're not doing aggressive exercises, but you're doing simple mobility exercises within neutral. So you don't need passive because the patient is able to do active. Okay, breathing exercises and all of that. Okay. Okay, not more than 5 METs. Okay, Beatrice, not more than 5 MET. Phase 2 is an extra phase which is given in Hill class, which is not given in your ACSM. We call this as a subacute phase. This phase is after the patient is discharged from the hospital and has gone home. So when he's at home, he's doing home therapy. That is your phase 2. What is the intensity in phase 2? Exact same as phase 1. You don't need to remember anything extra in phase 2. It is exactly what we see in phase 1. Everyone good with phase 1 and 2? Just the subacute phase is an extra phase which is given in your Hill class, which is not given in your ACSM. Is that clear? Exercise intensity is the same as 1. Okay. Now your phase 3 is your outpatient phase. It's usually for a month. For a month, they are usually at home. So it varies from patient to patient. It's not fixed. Your phase 2 is usually for a month. Okay, phase 2 is usually for a month and it varies from patient to patient. Okay, it could be longer, but your phase 3 is going to be your outpatient phase. What is important in this phase? This phase is usually, again, it's going to last like after the patient has come back from home. What is the first thing that you do in phase 3 before prescribing intensity? You do an exercise tolerant test. So you come to know what intensity you can give the patient. Do you do a maximum or a submaximal tolerance test? You do a submaximal exercise tolerance test. Excellent. Okay. Do you require monitoring all the time, or you do require monitoring only during exercise? Monitor only during exercise. What is the RPE that can be used here? It can be not more than 9 but ideally they will be somewhere between 4 to 6, but you can go all the way up to 9 if they can tolerate, but not more than 9, and 4 to 6 is the MET. If you have 9 MET, it is an exit point from the outpatient phase. Is that clear? What is the RPE? 13 to 16 is the RPE. These are values you have to memorize. It's not something I can help you. It's these are values we have to memorize. If it's 11 with inpatient, then 30. If it's 11 with inpatient, then it's going to be 13 to 16 with your outpatient phase. Okay. What is the heart rate? What is the heart rate that we use? Can I say 60 to 80% of heart rate reserve or VO2 max? Yes, but remember, you cannot go all the way to 80 in the beginning. Okay, you cannot go all the way to 80. You have to wait, like you are at 60, that will be good. You are still in phase 3. Depends on your exercise tolerance test. Okay. All right. Okay. Okay. Excellent. So 1 second, 9 MET equal to 50% heart rate max. So is that not too low for, is 9 MET equivalent to 50% heart rate max? I don't think so. Check your, what is the 9 MET equivalent to? METs, I think METs are, your MET, that is your 9 is your, 1 minute. Your 9 MET is, 9 is 50 RP, yeah. Yeah, so it's 50 to 60. You're still at 60, right? You're still at 60. That's okay. Okay, it's never going to be exact, okay? But your MET is here. Your phase 3 is going to be like this is your RPE. This is not your MET, guys. This is your RPE that you are confusing with your MET. Okay, and 9 MET is a very high heart rate. Okay, so please don't confuse there. 4 to 6, 13 to 16, 60 to 80% of your heart rate reserve or your VO2 max. Okay, now your RPE is 13 to 16 here. Got it? Now, what is the difference in phase 1 and phase in the first 2 phase and the third phase? Now, how many times there you were exercising every day? Do you come to the outpatient clinic every day? No, you're greater than 5 METs, you are going to start coming 2 to 3 times a week, right? You're going to focus on endurance exercises. You're going to focus on endurance exercises. You're going to focus on improving the functional capacity. And what is the MET that is required to do daily activities? To do your activities of daily living, what is the MET that is minimum MET required to do your activities of daily living? Excellent. 5. 5 is the MET required to do your activities of daily living. If you can do 5 METs, what else can they progress in the outpatient phase? What else do they progress in the outpatient phase if you reach 5 METs? You can start light resistance exercises. Depending on the procedure that is done, the week at which you can start your resistance exercises varies, okay, depending on the procedure that is done. If you have had undergone a myocardial infarction, which week do you start resistance exercise? If you've undergone a myocardial infarction, you can start it at the 5th week. If you've undergone a CABG, CABG surgery, then you do your resistance exercises at the 8th week. And if you've undergone a PTCA, that is your angioplasty, then you can start resistance exercises at 3 weeks. So when you are in your third phase, outpatient phase, you start with an exercise tolerance test. Your MET does not exceed 9 MET, RPE is 13 to 16, and your heart rate is 60 to 80% of your heart rate reserve or your VO2 max. You do it 2 to 3 times a week. Focus on endurance exercises and then progress to light resistance exercise. What will be the work to the rest ratio here? You can move to 2:1 where you're doing more work and a little less rest as compared to the first 2 stages. Is phase 3 clear? Here they can do all exercises, upper extremity, lower extremity, all exercises can be done in phase 2. Unlike phase 1, they can do all exercises, walking, everything is fine. They'll come to the outpatient clinic for 45 to 60 minute sessions. That will be this thing. Okay, do we need to know in phase 2? Yes, we need to know these criteria in phase 1, it is important to know these criteria. You have to remember these. Okay, the same for phase 1 and phase 2, and phase 3 was a little different that I told you all. Okay, ideally don't. So if a person has undergone CABG, you are going to take some sternal precautions. That is no upper extremity heavy weight. What are the sternal precautions? Come on, tell me the sternal precautions. What are the sternal precautions? Let's discuss them before we move on. What are the sternal precautions? It's up to 60 minutes, 45 minutes to 60 minute sessions can be done in your phase 3. That is your outpatient phase. Yes, no resistive training for the first 8 weeks, no pushing, pulling, no lifting weights greater than 5 pounds, no doing full range flexion, no doing full range abduction, external rotation, don't reach behind back. What else? Don't use a walker that is too low. Don't get up from the bed by using your hand to push and get up. Yes. Okay, excellent. Those are your sternal precautions. You don't do horizontal abduction, external rotation together. For patients with diabetes, take more care because the wound healing takes longer. Teach them breathing exercises, teach them splinted coughing, splinting, sneezing, right? All this is simple. You all know your sternal precautions, right? Everyone knows the sternal precautions. You can do cycloergometry, Riddhi. There's nothing wrong in doing cycloergometry. You are doing an exercise tolerance test, right? So you can do it. Everyone good with phase 1, phase 2, phase 3? Everyone is good with phase 1, phase 2, phase 3, sternal precautions, when to start resistance exercise based on the procedure that is done? Perfect. Is this much clear? You are going to do cardiac rehab in Dr. Singh's class today also, so it just works out fine. You're going to get a reinforcement of what we've done. Okay, and what is the last phase? Last phase is the maintenance phase. Where does this phase happen? Happens in YMCA, community centers. What is the MET now? MET is going to be greater than 9. What are they? They are going to do self-monitoring. They again go to the YMCAs around 2 to 3 times a week. Exercise will still stay 60 to 80% of VO2 max, 60 to 80% of heart rate reserve, right? Because you are not suddenly increasing the intensity. Maybe they were able to do 65, now they'll be able to do 70, depends on them. Okay, so the exercise intensity still says 60 to 80% of your heart rate reserve, VO2 max. You're not going more than that. You're not going 100%. Okay, this is phase 4. Maintenance phase, around it goes on for about 6 to 12 months. They do everything by themselves in the YMCA, self-monitoring. This is your stage 4 of your cardiac rehab. Is that clear? Is everyone clear with the stages of cardiac rehab? Your RPE in this phase will be greater than 13. Your RPE in this phase will be greater than 13 based on the patient tolerance. Okay. It will be like the same thing like your outpatient phase, 13 to 16, greater than that. It's just the maintenance phase. Outpatient, they were anyways doing good. Now you just move them to a maintenance phase. Okay. The phase 3, duration same. It will stay 45 to 60 minutes. It all stays same. They will be exercising for an hour, like how you go to the gym and exercise for an hour, and they can continue this phase 3 for 6 to 12 months, or they can continue it lifelong. It's up to them. Okay, they can continue this phase. They do not require any supervision in the maintenance phase. Is everyone clear with these phases? So phase 1 is same, phase 2, yes. Yes. So Devanshi, your phase 1 had 70% of maximum heart rate. So that will have 40 to 60% of heart rate reserve, 40 to 60% of VO2 max. Phase 1, phase 2, same. Phase 3, we discussed the intensity. Phase 4 has nothing new, just that your MET will be greater than 9. Okay, and this patient will be self-monitoring themselves. Is this clear? Everyone clear with the phases of cardiac rehab? Okay. Now, some special conditions that I want to talk about before we end the class is, let's say that you have a person, you are exercising a patient with heart failure. Let's assume you are exercising a patient with heart failure. What are the special considerations that you need to take for a patient with heart failure? Firstly, you are never going to exercise a patient who has uncompensated heart failure or anybody who's showing any signs of decompensation. What are signs of decompensation? Shortness of breath, loss of appetite, bloating, weight gain, etc., etc. You are not. So that is one thing. So you always exercise only with a compensated heart failure. What is the intensity that you give? Your heart rate, your intensity is always going to be very, very low. You monitor all the time. You monitor during exercise, after exercise, before exercise. Why? To see that are they getting any kind of signs of decompensation or no. Monitoring is very important because they have a risk of getting signs of decompensation anytime. Can you only use heart rate for heart failure? Their heart rate is not really adequate, so you have to use multiple things: heart rate, RPEs, METs, VO2 max. You can use a combination of things with your heart failure. Another thing, too much extra warm up and cool down time. Extra warm up and cool down time. Why? Because if you don't give them extra warm up and cool down time, it is going to cause venous pooling. Okay. Can you give resistance exercises in the patient with heart failure? Only if the MET is, if their MET is greater than 5, only if they are able to do activities of daily living and all comfortably, only then you can give them light resistive exercises. Everyone clear with heart failure? Always monitor them before, during, after. Always keep their intensity low. When I say low intensity, is it good to say start with 40%? 40% of heart rate reserve, 40% of VO2 max? Yes. Always monitor them before, during, after for any signs of decompensation. Give them a good warm-up time, cool down time to prevent venous pooling. Never increase the intensity as a progression. Always increase duration first before increasing the progression. If needed, break down their exercises into multiple time groups. Don't give it all together. And you can give light resistive exercises if they have an MET of greater than 5. Is heart failure clear? And always use a combination of like RPE and heart failure, etc. Yes, you don't want to always exercise in supine because of the problem with orthopnea. So you have to be careful. Okay, so yes, simple, avoid breath holding, avoid Valsalva. All this is common for any other heart condition also. Okay, now cardiac transplant, another very important thing. Okay, this is an important point. I want you all to listen to me. What is, when a person is having cardiac transplant, that means a new heart, that means a new heart has come to your body. What will happen to the resting heart rate if it's a new heart? High. Imagine you at the first day in your clinic. You're very nervous. Your resting heart rate is going to be high, right? Are you going to learn everything in day one in the clinic? No. So your maximum heart rate is not going to increase proportionally to the exercise that you are doing. So whatever exercise you're doing, your maximum heart rate will not increase proportionally. Okay. What about the heart rate recovery? Will it be slow or will it be fast? So for a cardiac transplant, your heart rate, your resting heart, always remember these 3 points. Resting heart rate is going to be high. Maximum heart rate is not going to increase proportionally, and your heart rate recovery is going to be slow. So can you use heart rate as the only way of prescribing exercises with cardiac transplant? No, you can use RPE, METs, and a combination of other things. Which other condition do you not use only heart rate? One was heart failure, one was cardiac transplant, one was patients on beta blockers, calcium channel blockers. What else? patients on pacemakers. Even pacemakers, right? Because pacemaker means the heart is beating at a fixed rate. Is that related to will it change with exercise? No. Even with diabetes, yes, diabetic patients have a fixed heart rate when they have diabetic autonomic neuropathy. Good. So even for them, only heart rate cannot be used. Okay, everyone clear with the conditions you cannot use only heart rate? Heart failure, cardiac transplant, pacemakers, diabetic autonomic neuropathy, calcium channel blockers, beta blockers. Everyone knows their sternal precautions? Excellent. Okay, good job. CCB, what is, okay, you mean calcium channel blockers? Yes, for calcium channel blockers, also we are not going to use. Perfect. Okay, now if I give you a question, okay, I want you to answer me this question, okay. Let me see if I have it. I've written it somewhere. I don't know if you can find it, but okay. If I give you a question that says that a 70-year-old patient recently got a heart transplant, okay, I'm going to write it here. A 70-year-old patient recently got a heart transplant. Few weeks back, I can say few weeks back. Okay, what protocol should I use for prescribing intensity? Should I give him exercise intensity 5 days a week at an RPE of 13? Or should I give him exercises at 50 to 70% of heart rate reserve 5 days a week? Come on, pick. I knew a lot of people will pick B, but what did we study? This is how your exam is going to trick you. What did this patient have? Will you use heart rate? That is why your question will be, this will be your, that is why your answer will be 5 days a week, RPE 13. Now understood how they are going to ask you, which is why I told you special consideration. Yes, I'm just collecting my jar of hearts. Okay, yes. So these were my special considerations. I warned you guys. I told you heart failure, cardiac transplant, pacemakers, your beta blockers, calcium channel blockers, diabetic, don't use only heart rate reserve. Okay, don't use that. But you still did. Okay. Yes, it does. It are good numbers. That's correct. They were proper. They were exact numbers that you had to choose. But it was only because it was RPE you couldn't choose that. Okay. You don't consider heart rate if there is a heart transplant or anything because you cannot only depend on that. Okay. One last before I send you for the next class is another question. Now, a patient with a history of angina has been referred to the outpatient physical therapy clinic for exercise rehab. Okay. No, we don't use B-trees because pacemakers have a fixed heart rate. You cannot use only heart rate. Okay, so angina, a patient with a history of angina has been referred to the outpatient for exercise therapy. What are you going to use? Are you going to use treadmill exercises at 70% of heart rate reserve 3 days a week with exercise to rest ratio of 2:1? Or are you going to use 70%? My options are going to be tricky from first, I'm telling you. 70% of VO2 max 5 days a week with exercise to rest ratio 1:1. Come on, tell me which one. You all are going to go back and listen to this lecture because you're going to beat yourself up. What is mentioned? What is the phase? Outpatient phase, phase 3 of cardiac rehab. How many days a week do you do outpatient therapy? 2 to 3 days a week. What is your exercise to your rest ratio? I purposely kept the same intensity because I wanted you guys to get confused there. But didn't you all know 1:1 and 5 days a week was your phase 1? Now understood why it was A? That's where we end your cardiac rehab and exercise prescription. I know you guys hate me for today's class because it was a very complicated one, but I want you all to do it again. Okay, I want you all to do this again because this will really help you. Okay, these phases of cardiac rehab, this exercise prescription is what you need to know for your exam. I love you all a lot. I know I tortured you all today, but I really want you guys to know this today. Okay, listen to this class once more, find time, listen to this, get the exercise prescription clear, get the stages of rehab clear, make your key points when not to use heart rate, and you're going to get this absolutely right. Okay.
Can I ask a question, please?
Good. Last slide, this one, yes, Devanshi. So the answer here was A. Yes. Okay. You all can sign off. Okay. Have a great evening.
I had a question
because I know you have to rush to the next class, but I am here. I know this was a complicated class. Let me stop the recording. Yes, Anushka, go ahead.
For the last question that you asked, if the patient has angina